I wanted to thank Gail and the rest of the team for inviting me to introduce our next speaker. And that is Dr. Richard Botner, who is joining us from Texas to provide a deep dive into stigma, how it permeates into healthcare, and how one team in Texas worked to change the minds and the organizational culture in a quest to improve care. Dr. Botner is an affiliate member in the Department of Internal Medicine at Dell Medical School at the University of Texas at Austin, and a physician assistant in the Division of Hospital Medicine at Dell Seton Medical Center. He is the director of the buprenorphine team, or the B team as they call it, a full service consultation team that provides patients who are hospitalized and have opioid use disorder access to treatment and linkage to appropriate outpatient care. All those handoffs are just so important as you move from acute care in the hospital and out to success in the community. He's also the director of Support Hospital Opioid Use Treatment, or SHOUT, as they call it in Texas. And that's a program seeking to increase access to opioid use disorder treatment in hospitals, not only in the Austin region, but across the entire state of Texas. In addition, Dr. Botner was the first physician's assistant in the country to be certified to teach the buprenorphine certification curriculum through the American Academy of Addiction Psychiatry. Thank you for joining us, Dr. Botner, and the floor is yours.
Well, thank you so much, and hello to you all. Let me just make sure, can you all hear me okay? All right, fantastic. And let me just go ahead and share my screen. All right. Hopefully you can see my screen now. So
looks great.
Perfect, thank you. So thank you so much for having me today. I'm really excited to be able to share this content with you. It is an area that we are so passionate about for so many reasons, as I think you will hear throughout this presentation. This really isn't meant to be sort of a heavy, clinically oriented, pharmacology type of presentation. So you can sort of, take a load off and kind of get in a good headspace. This is really going to be an exploration about stigma and how stigma affects our systems practice. And I can tell you from the work that we've done here in Austin for the last 4 years that of the many barriers that exist for patients to receive evidence-based care in the hospital and in the community, by far the biggest barrier of all, really what I would call kind of the root barrier that leads to all the other barriers that we face, is stigma. And so that's really what we're going to focus on today. I have, yes.
Oh, I'm so sorry to interrupt. You were getting a bit of feedback from your mic.
Oh.
Try muting yourself, unmuting, sometimes that.
All right, let me see. I'm going to mute myself, but then I won't be able to hear you. Give me 1 sec. I'm going to mute my... Can you just chat me if this works? Give me 1 second here.
Sure.
All right, I muted my speakers. Did that help or did that make it worse?
About the same. Oh, about the same on our end. That's okay. We can still hear you. We're just getting a little bit of feedback, so I think you can carry on.
Okay. I can call in on my phone if we think that might be a little bit better. That'll only take a second or two.
Yeah, that might be cool.
Okay, give me just 1 sec. Sorry about that, everybody.
Welcome to Zoom. Enter your participant up.
All right, is that better now? Hopefully that is. I apologize for. Okay, thank you so much for letting me know. They promised 2021 would be better, everybody. So, all right. Back to the show here. So I have no disclosures to share, other than I'm from New Jersey, and I'm very passionate about this topic, as I mentioned earlier, so I will try not to talk too fast. Usually I say I'll try not to use my hands too much, but the virtual part of this kind of has kept me grounded from using my hands too much. So let me just sort of start with a bit of a story that I think will resonate with many of you today about why I'm so passionate about this and why I am a person who's really appropriate to be speaking with you about this today. And it actually goes back well over 10 years ago when I was a EMT in New Jersey, which is where I grew up. And I worked for several public safety agencies over the last 15 years, both in New Jersey, in the Boston area, and the Connecticut area. And one of my major takeaways from doing that work, which again was well over 10 years ago at this point, was that when we would go on calls and we would meet people in their homes or in the streets, and people who were having issues related to substance use, we often made a lot of assumptions about what the backgrounds of those people might be like, what were the circumstances that may have led those individuals to use substances. And I can assure you that these assumptions that we were making were really not good ones, right? They were not positive ones. And I developed a lot of bias around people with addiction and people with substance use disorders. And, fast forward 5-6 years, decided to go to PA school. And you would think that in this sort of academic environment of being trained to be a healthcare provider, that there would be sort of systematic ways that those biases would be decreased, that they would be reduced. And in fact, as the experience of many people who go through healthcare training, not just PAs like myself, but nurse practitioners, physicians, pharmacists, et cetera, the stigma, the bias was actually amplified. So many of the test questions that were in my exam, many of the lectures and the presenters that came to teach those lectures, they used cases, they used examples, they used language that actually amplified the stigma that I had kind of started out when I was working in New Jersey. Moving on, when I started doing my didactic training, my clinical training, I would go out into the field and I would be with preceptors. And again, you would expect that stigma would be reduced, but again, it was amplified in my ER rotation, my primary care rotation, really all of my rotations. And so the biases that I had cemented for a very long time were amplified, were echoed. And when I took my first job as a clinically practicing PA, I brought all of that with me. And so I've been working in hospitals ever since. I love what I do as a hospital medicine provider. But I was that clinician who would see a patient who had a history of intravenous drug use, who maybe had endocarditis or maybe had a skin and soft tissue infection. And my goal was to interact with those patients as little as possible, was to treat their withdrawals as best as I knew how, which often was a combination of sort of adjunctive therapies like clonidine and Zofran, usually giving relatively high doses of oxycodone or morphine, because the last thing that I wanted to have happen was for a patient to have withdrawal symptoms during their hospitalization. And of course, these feelings that I had about trying to treat somebody as quickly as possible and discharge them as quickly as possible were not feelings that were just held by me. They were held by many of my colleagues as well. And it wasn't until about 4 years ago when I had the opportunity to start a quality improvement project around increasing access to buprenorphine for opioid use disorder during hospitalization that I truly realized that all of my assumptions for years, for over a decade, were so wrong, that there was so much that I didn't know and so much I had to learn about not just the clinical aspects of substance use disorders, but really the systems practice. The systems practice is probably the biggest gap of all that we have. How do we as a healthcare system at the micro level, at the macro level, how do we as a society want to move forward in how we address substance use disorders and people with addiction? And so I've been on a recovery journey of my own, if you will, in the sense of really trying to understand people with substance use disorders and how we can best possibly serve them in our current environment, but really, moreover, how can we improve the environment so that we can provide optimal, amazing care for people with substance use disorders. And so, the stigma that led me on this journey originally, I'm happy to say, has been much reduced. I still catch myself at times, thinking about something in a really biased way. And so I would encourage all of you as we embark on this journey together for this presentation that you may come at this with your own biases, even if you're super passionate about this line of work and you've been doing this for a long time, we all have our own biases and our own stigma, and that is amplified and shared with learners if you're in an academic environment. It's certainly felt in patients, it's felt by policymakers, and so we all have a role in decreasing stigma and ultimately improving care. So that's what we're going to talk about today. And my suggestion for you for this next 45 minutes that we have together, that we sort of take our ideas, our preconceived notions, our stigma and our biases, and we try to just put those aside and ignore them, put them on the train and send them down the track so that we can focus on potential solutions. So that's my story. I'm sure many of you have a similar story. Today we're going to talk about what is stigma, why is it important, what are the different forms, how does it decrease access to care, and then I'll tell you a little bit about the work that I have the privilege of leading here in Austin and how we have subsequently reduced stigma. So I started to mention this a little bit earlier. The program that we started here, which I'll talk a little bit more about towards the end of our presentation today, is a volunteer program, a volunteer-based program where we empowered the healthcare practitioners who are already employed in our hospital to do the right thing, to do the evidence-based thing, which is to initiate buprenorphine for people during acute hospitalization. 4 years ago, when we started this work, we were the only hospital in Texas that starts buprenorphine therapy during acute hospitalization. And 4 years later, we are still the only hospital in Texas that initiates buprenorphine as part of our regular standard of care, our regular practice. And so the question that we often get asked by other institutions in Texas is, well, why? Why are you the only hospital that does this? And I would say there's three main buckets as to why we don't improve care for people with OUD in hospitals. One is education. So we've not done a great job as an overall healthcare community, as a medical education community, to make sure that healthcare professionals, and I say that term very broadly, so not just prescribers, but social workers, pharmacists, all members of the healthcare team have a true appreciation of what substance use disorders are and how we treat them. So education is improving, it's getting better, but that's definitely a gap. Two, again, is that systems practice, the regulatory environment, the legislative environment, the reimbursement environment, all of that systems-y stuff. But then three, which is the focus for today, is stigma. And at the end of the day, when you combine all of these things, when all of these things collide and make it so challenging to improve care, many people sort of just shrug their shoulders and they go, this is too complicated. This is an outpatient issue. We're not going to address this in the hospital. And so the journey that we've been on for the last 4 years, sort of our soul searching, has been to change that mindset, not just amongst our frontline healthcare workers and internal medicine folks, but really across the entire institution, including our administration. So if we're going to talk about stigma, we have to have a shared definition of what stigma is. And the origin of stigma comes from the Greek word stazine. And a stazine back in ancient Greek times was a mark that was burned onto the skin of slaves to signify their low place within the social hierarchy. So this was a physical brand that was burned onto human beings. And so that's the origin of the word stigma, the term that we use today quite broadly. And there's two other definitions that are really important to consider, and I'm not going to read these both to you, but the connection between them, and they're about 40 years apart, right? One from 1960, one from 2002. The definitions haven't really changed all that much, but basically what we're saying is that stigma is a two-part process. So part one is that there has to be a distinguishing mark. There has to be that stazine. Now, of course, today we don't physically brand people, but we still mark them. We mark them in the language that we use to talk about them with our colleagues. We mark them in the language that we use in the medical record. We mark them in terms of policies that we put in place that ultimately result in disparate care. And of course, on physical exam findings for a patient who maybe uses intravenous drugs, there are physical findings that we see, physical signs of substance use disorders and drug use. And then the second part is that there has to be this sort of devaluation of the human being. So at first we mark, we use that language, and then we devalue them. We devalue them as practitioners, as I perhaps once did. We devalue them in terms of how we approach them within our system, in terms of how we prioritize the diagnosis. And then we devalue them in terms of all of the opportunities that are no longer available to them. And of course, today, we're going to be speaking specifically about healthcare, and really healthcare within the hospital. But of course, we all recognize that when we talk about disparate care for people with substance use disorders and addiction, it's not just about care, right? Healthcare is a very broad term for many people, and it has to include employment, it has to include housing. It's really all of these opportunities that are stripped away from people who use drugs, specifically around or as a result of stigma. And so what exactly is stigma? I kind of gave you a broad sociology type definition, but how does that actually translate into what we're going to talk about today? And I think it's important to tease out a bunch of these other terms that often come up when we talk about stigma. And I sort of see it as kind of a linear process. So there are stereotypes, there are prejudices, and then there is discrimination that results. And so stereotypes are beliefs that one group of people have about another group of people. And often in conversations that we have, we identify stereotypes as being the evil. And in reality, most sociologists agree that there actually isn't a lot that we can do as a society around stereotyping. In other words, stereotypes are beliefs. So a belief that one group might have is that, people who use drugs are bad, right? That's a belief that one group of people has about another group of people. It's not a belief, of course, that I have, but those beliefs in and of themselves, there's little that you can do, because as you try to manipulate certain beliefs, you end up creating new beliefs in their place, and the accuracies of any one group's beliefs are kind of questionable, right? So most sociologists agree, even if you go back to sort of biblical times, there's not a whole lot that we can do about stereotypes. And again, it's only the belief part. It's a thought. However, oftentimes these beliefs progress into feelings, which result in prejudice. So if you have a belief that a person who uses drugs might be bad, then the feeling that often gets generated from that by healthcare providers and the general public and policymakers alike is a feeling of resentment. It's a feeling of fear. It's a feeling of hatred sometimes, right? So it's all of these negative feelings that we apply to groups that we stereotype, and I use we very broadly. And it's those feelings that ultimately result in discrimination and marginalization. And we all can agree that discrimination and marginalization is a bad thing. And that is exactly what we're here to talk about today. So it's important to sort of be able to tease out what how these terms relate and how they're different. And at the end of the day, this is all about reducing discrimination. And the root of discrimination in this case is stigma. Last thing I'll say, just to sort of round the conversation, is that there's three types of stigma that I think is really important to appreciate. And I didn't appreciate, I could sense this, I could feel this, both in my organization and in the advocacy work that I do, but it really helps to have this sort of framework. So the first type of stigma is social stigma. And when you saw on the agenda for this meeting that there was going to be a talk about stigma, you most likely were thinking about it through the lens of social stigma. Social stigma is kind of an abstract-y thing, but it's basically if you're sitting around with a group of family members or friends or even your colleagues at work, and you start having conversations about people who use drugs, and those conversations often have lots of sort of assumptions that are built in, lots of things that get pulled from like the media, for example, or if you're walking with a group of people that you know down the street and you sort of see somebody who the group identifies as a person who uses drugs, the sort of avoidance of that person, right? Maybe you cross to the other side of the street. This is all examples of social stigma. So it's how you talk about and feel about people who use drugs in a social setting. Again, using the term social pretty broadly: family, friends, work, etc. And that's the one that most people think of when they think about stigma. But there's two other important ones here that we have to highlight. One is structural stigma. Structural stigma is synonymous with policy. And when I say policy, I'm using that term very broadly. Institutional policy within your own hospital, for example. It could be local policy. It could be regional policy. It could be policy at the state level or the federal level. They are policies that we put in place that ultimately create disparate care, right? That makes it much harder to deliver care for one group of people than another group of people. And you may not have seen this because I know you all had a session before this. This is hot off the press, so I hope that I'm the one giving you the news here. But one of the biggest forms of structural stigma in the work that I do is the X waiver, right? The fact that you have to go through 8 hours of training as a physician or 24 hours of training as a PA or nurse practitioner to prescribe this life-saving medication, to get this X waiver certification is an excellent example of structural stigma. Hot off the press, Biden administration just announced that effective tomorrow, the waiver is going away for most prescribers. There's some nuances there that I'm certainly not going to talk about now. I actually was trying to read about it before I came on here, but this is big news, right? And so that's an example of changing policy in order to provide better care. And I think we all can agree that getting rid of the waiver will ultimately provide better care for our patients with opioid use disorder. So that's an example of structural stigma. And then the third is self-stigma. Self-stigma is one that we don't talk about enough at all. And it's the stigma that patients feel against themselves, people who use drugs. And it actually explains so much of the hopelessness that we often see in people who have had substance use disorders for a long time. And I want to be clear in saying that self-stigma is a direct result of social stigma and structural stigma. And it also is kind of this linear process where at first you have awareness. So society starts to say that people who use drugs are bad. We start to raise awareness. We start to sort of have this theme, this narrative play out in our general society. We see it in movies. We see it in the media. We sort of start getting these ideas percolating that people who use drugs, are bad. And the more that we see it as a society, the more that we believe it. So we start to agree that people who use drugs are bad. Well, the person who uses drugs over time sees this, right? They see this in the media. They see this in their family. They see this in their friends. They see this in their workplace if they're fortunate to still have a job. They see this when they try and access care in the healthcare system. They see time and time again that we as a society have decided that people who use drugs are bad, and they apply that to themselves by saying, if society says people who use drugs are bad, I use drugs, therefore I must be bad. And this results in harm because it ultimately results in what's called the why even try effect, right? So if you're told every single corner that you turn, every single person that you speak to, including your close personal friends, your contacts, the healthcare system, your employment system, the housing system, every corner that you turn to, you hit a barrier and you get told that you are that you're undeserving because of your substance use, then ultimately you say, why am I going to even try? And this is actually an extremely important principle for hospitals, because one of the questions that I often get from hospital administrators is, why don't we do a better job of this in the outpatient setting? How come we're waiting until patients present to the ER with life-threatening heart infections, skin infections, spine infections, and having these, prolonged, expensive hospitalizations? Why aren't we doing better in the outpatient community? And this is a huge part of the answer, that people with substance use disorders don't want to seek care because they've been told for months to years not to seek care because they don't deserve care. And so they don't show up in the healthcare system until it's so severe, so life-threatening that the only place they can go is to a hospital. And so many of the people that we see in our hospitals, I'm sure you see in yours, have this profound sense of hopelessness. And this explains so much of it. So when we start talking about stigma, these three areas are just so critically important. They're not just sort of, I'm not a sociologist, by the way, I'm just sort of well-read in the topic, but it really applies to the work that we do in hospitals in a pretty profound way. And I want to recognize, by the way, that I'm trying to distill some thoughts and ideas and things that we've learned in the last 4 years of doing our program into a short presentation here. I recognize, we all need to recognize, stigma is complicated. Canada invested millions of dollars and several years solely on the topic of stigma. They really wanted to understand how they as a country could approach stigma of addiction. And they had these big work groups, and people traveled across the different territories in Canada. And they ended up putting all of it into 4 buckets. So one was describing what stigma is. So what is it? What does it kind of look like? What does it feel like? What are the impact of stigma? How does it get in the way of people getting care? What are the sources of it? Sort of where are all the tension points? What are the contributing factors? And then finally, how do we tackle it? How do we get rid of it? And I think if we look at stigma through this framework, if we look at it through this lens, it actually makes understanding how we get rid of it much easier. And I'm not going to go through the whole framework, but I'm sharing this, right? This is like the whole framework, and the actual document is 100 pages long. So I'm not going to go over that today, obviously. But I want to take some space to appreciate that stigma is really complicated. But the way that we start to move forward is by having the conversations that we need to have. And when I talk about the work that we've done at our institution in terms of starting buprenorphine, yes, that was a successful clinical program that we started, but what it actually did was empower people to have conversations that they weren't having before, to have a safe space for people to have really challenging conversations about how we as a hospital, we as a city, we as a state and a society want to approach addiction in a meaningful and more holistic way. Those conversations were not happening before, and that's part of how you reduce stigma. I want to make a note that we often, one of the solutions to stigma that we'll certainly touch on here is making sure that we're using appropriate language, but the language that patients may use to describe themselves may be different than the language that we use to describe patients. And I want to just take some space to share that that's okay and that we should encourage that. So in one study at a Massachusetts substance use clinic, they surveyed over 250 patients, and those patients referred to themselves the most as an addict, right? Addict is not a term that we as healthcare professionals should ever be using, but if a patient refers to themselves as an addict, perfectly acceptable. And I want to sort of just double down on that by saying in the same survey, they asked patients, okay, you're of course free to use whatever language to describe yourself that you would like. What are the terms that you would like healthcare providers to use to describe you? And what you'll see on the left there, person who uses drugs, person with a heroin addiction, person with a heroin dependence. What you're seeing here is person first language. So when I was in training, if we were presenting a patient who had diabetes and we said the diabetic patient, we would get in big trouble, right? Because it's always the patient first. It's a patient with diabetes. It's a patient with heart failure. We don't necessarily apply those same rules to people with substance use disorders, and we ought to. We must. So it's a person with a substance use disorder, and we'll talk a little bit more about language towards the end here. So how does stigma get in the way of clinical care, right? I've given you a lot of information about kind of what stigma is, why is it important, how does it apply to the work that we do in the healthcare setting, and really in hospitals, right? We know that people with substance use disorders are viewed negatively by many healthcare professionals, many of our own colleagues, right? And we know that when there's stigmatizing language in the medical record, that people get less treatment of pain, right? I'm on clinical service right now, and I am part of a surgical co-management service. So we take care of people with orthopedic surgeries and plastic surgeries. And of course, some of those people have substance use disorders and opioid use disorders. And I can tell you from my own experience and from my colleagues' experience that when you see language in the record that implies drug-seeking behavior, and I'm using air quotes very intentionally, or if you see history of substance use, that all of a sudden everybody's extremely cautious about ordering any type of pain management, right? And these are people who in many cases are having very complicated surgeries, and you would expect that they would have pain after, and yet their pain gets treated less, and this plays out in the literature across many institutions. We also know that at least for medical students and for physicians, and there is some emerging literature that this is true for other health professions as well, which I would anticipate that it would be, that unlike other areas of clinical training that you would expect to get better over time, right? So the more hands-on experience that you get in anything, whether it's medicine or something else, you would expect that people would get better over time. And of course, that is what you see in terms of clinical skills, that clinical skills get better the further you're out from your training. However, stigma is inverse to that. So stigma gets worse, and they did a really awesome longitudinal study. They followed medical students into their residency, and then they followed them from their residency into when they were attending physicians, and the stigma around substance use disorders and addiction got worse throughout that entire time, right? And that says a lot about our health professionals the training system. It's a lot about the mentorship that we have. It does a lot about the clinical environments where our trainees are getting their education. And again, this is not attacking physicians in any way. This is a health professions training issue. This is why the National Academy of Medicine has a work group made up of all of the educational entities that represent healthcare professions, not just physicians, PAs, nurses, pharmacists, dentistry, any and all healthcare providers, right? Because this is a all hands on deck. Everybody needs to benefit from stigma training. In terms of how this turns out for individual disease states, and there's lots of examples of this. This is just a little taste of it, but we know that people with hepatitis C who need a liver transplant, who are engaged in buprenorphine therapy or methadone therapy, they are often told that they need to come off of that therapy. They need to stop buprenorphine or methadone in order to get a life-saving liver transplant, right? That's a problem, right? Buprenorphine, methadone, naltrexone, evidence-based medications endorsed by countless organizations, approved by the FDA, are safe and effective, and yet we're telling people that they need to come off of them. That's all driven by stigma. We know for people who have endocarditis from intravenous drug use, so infective endocarditis, that they are often told by cardiothoracic surgeons that they will not repair their valve. This has a lot to do with changes in how CTVS services are rated and the metrics that they submit. And so again, this is a good example of structural stigma, that the metrics that have now been submitted or that have now been sort of mandated make it much more challenging for CTVS services to want to provide surgery. It also has a lot to do with social stigma, right? Because the automatic assumption is that if you replace a valve for somebody who uses intravenous drugs or has used intravenous drugs, that you will undoubtedly have to just replace another valve down the road. And of course, we know that that is often not the case. That is most often not the case. But there's such a fear for getting dinged in the metrics around having to do a second valve replacement that this prohibits many people from having this life-limiting, often life-threatening complication of intravenous drug use treated appropriately. And then, of course, we don't talk enough about pregnancy and the extreme amount of stigma that is placed on pregnant women who use substances. It's described in the literature as a double stigmatization, and so there's so much more that we need to do for pregnant patients around substance use disorders, and stigma is by far one of if not the largest barrier for them. We often look at substance use disorders as a moral failing, right? That is, probably not many of us on this call today, right? Because we're all sort of drinking the Kool-Aid. But for many of our colleagues, many of the folks that we work with, substance use disorders is seen as kind of a moral failing. Like, why don't you just stop, right? This is your choice to continue using. And in reality, we know that substance use is driven by genetic and environmental factors. And what I really want to drive home here is that the rates of recurrence, or what we often call as relapse, is really very similar in substance use, if not better than what we see in other chronic medical diseases. Now, I tell you, I'm on service right now, and yesterday I admitted a patient who has a blood sugar of 600. I looked back in his medical record. He was admitted for the same exact thing 1 month ago, and when he was admitted for that 1 month ago, this was a person who has a long-standing history of diabetes, so not a new diagnosis. Last month, when he was admitted for a blood sugar of 600, he was provided diabetic counseling. He was provided a prescription for insulin, which was delivered to his bedside before he discharged. We made him a follow-up appointment at our Bridge Clinic to make sure that he could have his blood sugar checked and that he was doing okay. We plugged him into our nurse phone hotline, so the nurses were calling him every other day to make sure that he was doing okay from a blood sugar management perspective. And then for a variety of reasons, he didn't use his insulin. He came back yesterday with the same exact presentation. Did we stigmatize him? Did we berate him? Did we say we're not going to give you another prescription for insulin? Did we say we're not going to get you set up for success again when you leave the hospital? Of course not, right? We do all of those things because that's what we do. That's what we do in our safety net hospital. That's what we do in all of our hospitals for most diagnoses, with the exception of substance use and addiction, right? And so even though substance use and addiction is a life-limiting, life-threatening condition, people come to hospitals in crisis we should be set up to help those individuals just like we do for other individuals who are in crisis. I want to be very clear in making a distinction that in the work that we do and the work that we've done, we don't advocate at all for hospitals to become treatment centers. That is certainly not the message. Hospitals should not be treatment centers. The hospital is not where you should go for your daily methadone, buprenorphine, counseling, etc. But when the reason for not just one admission, but repeated admissions, when the root cause of that is a substance use disorder, and all we do is treat sort of the distant downstream medical complication of that substance use disorder and not the underlying problem, which is the addiction, we're doing a disservice to the patient, we're doing a disservice to the care team, and of course we're doing a disservice to the healthcare system, right? The expense and the resources that go into caring for patients who really we could set up for better success to avoid those readmissions, right? And so addiction, very similar to many of the other chronic diseases that we see in our hospitals. I want to just make sure that we're sharing the American Society of Addiction Medicine definition for addiction. I'm not going to read the whole thing, but I do want to kind of tease out the first part there, that addiction is a treatable chronic medical disease, right? Very important, just like other diseases. It's treatable, it's chronic, it often waxes and wanes, right? So there are periods of time in a person's life who has a substance use disorder where they're doing really well, and there's times where they do not so well, just like other chronic medical diseases. This is an uphill battle. I mean, we're talking about healthcare providers and hospitals today, but in some ways, our opinions about substance use and addiction is a mirror of general society, right? When we're not in our healthcare setting, that's where we spend our time, right? In general society. And so, how does the general public feel about substance use and addiction? Not so great, as you might imagine, right? They're often seen as people who are reckless, who are unreliable, who are undeserving, who are threatening, who are hopeless, who are blameworthy for their substance use. And it's often seen as being very closely linked with other conditions that are also seen as highly stigmatized. So hepatitis C, driving under the influence, HIV, and actually in one survey, right, 1,000 adults across the country, geographically diverse, 75%, so 3/4, felt that people with opioid use disorder were themselves to blame, right? So we have a lot to do, but it takes individuals like you, it takes the time to start thinking about how do we tease some of these themes out, how do we have some of these challenging conversations to really start to move that ball. I want to make sure that we are touching on drug policy here, and I could talk all day about this. I could talk all week about this. This is a really important topic to recognize and appreciate. And when you have conversations in your community and in your organization about stigma and how stigma has affected people who use drugs, you must talk about drug policy. And you have to talk about systemic racism and structural racism as it relates to criminal justice and policy, because that has fueled so much of the stigma and has fueled so much of the disparate care that we see. No surprise, I'm sure, to many, to most, to all, that drug arrest rates in Black communities and brown communities is far beyond that in white communities. And this all stems back to the war on drugs in the 1970s. And back then it was focused on cocaine. Today it's focused on heroin. Just to give you some very rich history here, because I think it's just so important that we appreciate this. This is a very good example of structural stigma, where back in the 1970s, we decided that we were going to arrest and incarcerate people for possession of cocaine based on the weight, the amount of cocaine they had in their possession at the time of arrest. And in Black communities and brown communities, it was predominantly rock cocaine, and in white communities, it was predominantly powder cocaine. The rock cocaine was less expensive, and you can imagine it would be much heavier because it's in rock form. That had a much heftier sentence, a much harsher penalty than white light powder that was found in white communities. And this today continues to create such disparate care. The war on drugs continues despite most people who these things arguing that it has not been truly effective, right? The criminalization of drugs has been very ineffective and in many ways has contributed to many of the issues that we see, large disparities among individuals of racial minority groups, and to be very clear, if you are white today and you are interested in buprenorphine or methadone for opioid use disorder treatment, you are 35 times more likely to receive that than if you are Black. And that says so much about the foundations and where we're at, the history, and so we are making progress here. It is slow progress, and I think many, if not all, would agree that it is too slow. Right? The gap here, any gap is a gap too large, and the gap today is just really atrocious. So I won't say more about that now, but I really want to recognize this. And as you're sort of noodling through how to raise these issues in your own organization, if you're not touching on the history here and the structural racism that's been baked in for 50 plus years, really hundreds, but in the context of drug policy, 50 plus years, really important part of the conversation for our communities. All right, so let's change focus just a smidge and talk about how hospitals come into play. How do hospitals have a role in all of this, which I know is, that's where most of y'all spend your time, certainly where I think I spend more time in the hospital than I spend at home. I have a feeling that most of you are in the same boat. So how do hospitals come into play here? So one, we have to have an understanding that hospitals are critical access points, and that really for opioid and substance use in general, that there's a lot more we can do around screening, management, treatment, harm reduction. These are things that we can do much, 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 much better. And I really want to bring this is my last sociologic principle for everybody today, but it's an important one, which is NIMBY, not in my backyard. And NIMBY can be best illustrated by some things that happened in different parts of the country earlier on in the opioid epidemic, where communities, states, passed large bills, essentially passed tax hikes to their communities, to their residents in their states, trying to build better infrastructure for substance use treatment. And in many states, especially states that were hit the hardest early on by the opioid epidemic, there was overwhelming support. So even though people generally don't like taxes, they were willing to support these bills because they knew that the degrees of separation was not 6 or 5 or 4. It was often 1 or 2, right? Everybody knew somebody who either died to an overdose or who had a serious adverse life event around opioids. So the communities rallied around all of this. And the bills passed and the money started flowing. But then when it came time to actually build the infrastructure, literal physical infrastructure, to build treatment centers, treatment programs, pretty much every community that had supported these bills in many states all turned around and said, oh, no, drug treatment is important. But yeah, no, not in my community, not anywhere near my house, not anywhere near where I shop, where I work, where I play, et cetera, right? And so this idea of NIMBY is really important because it happens in hospitals. When we started doing our work here in Austin, early on, our hospital leaders pushed back. And they weren't pushing back in the sense that I don't believe in drug treatment. I mean, these are wonderful leaders. They're evidence-based practitioners, and they said, we understand the evidence behind buprenorphine and methadone, and thank you so much for a great presentation. But hospital is not the right place to do this. This really is an outpatient problem. NIMBY, not in my backyard. I support it, but not in my hospital. And it took advocacy. It took having successful buprenorphine initiation. It took having patient stories. It took having advocacy, not just from internal medicine providers, but nurses, pharmacists, social workers, interprofessional advocacy in the organization to really send the message that this is important and we're not doing what we should be doing. Let's try this. Let's do, in the spirit of Institute for Healthcare Improvement, right? PDSA cycles. Let's make sure that every week to 2 weeks we're meeting and we're evaluating our progress. But let's do this, and that's what we did. It took time, didn't happen overnight. But this idea of NIMBY was by far our biggest barrier early on. And so if you're drinking the Kool-Aid so far in my talk, and you're thinking, okay, this is important. We have to destigmatize substance use. We have to increase access to treatment. But maybe not in the hospital. I want you to think about NIMBY because this is a all hands on deck national crisis. and I'm sure the speakers before me talked about the impact of COVID on substance use and opioid use disorder overdoses. So this is a crisis, right? This crisis did not go away because we were distracted by COVID, right? And because we're burned out by COVID. I totally understand that. But this crisis is still here, and as the data suggests, continues to get worse. So at most hospitals, we're really good at sort of treating withdrawal. This is what happens at the other 599 hospitals in Texas today. Still, 4 years later, a patient comes in, they're going through opioid withdrawal, but they're not coming in for that. They're coming in for the abscess. We treat that withdrawal as best as we can with anti-anxiety medications and anti-nausea medications. But we know that 30 days after discharge, 80% of people who misuse opioids will continue to do so. So even though we feel good about getting a patient through that really uncomfortable opioid withdrawal in the hospital, if we've done nothing else but treat the medical issue, not the underlying issue, if we didn't start buprenorphine, if we didn't provide naloxone, if we didn't refer to an outpatient clinic, if we didn't provide a peer recovery specialist, if we didn't provide any sort of counseling intervention, if we didn't do any of those things, then we're part of the problem. We've contributed to 80% of people misusing substances again within 30 days of hospital discharge. And of course, as I'm sure we can all appreciate, working in the hospital setting, this ultimately contributes to high readmissions, right? So in a way, we are contributing to this sort of vicious cycle of substance use that many of our patients experience, and quite frankly, that our hospitals are often seeing high numbers of. And again, just to kind of drive this home, we often talk about the burden of hospitals or on hospitals as a result of opioid use disorder being specific to overdose or withdrawal. And it's actually so much bigger than that. We have to think about it more holistically. Patients that we're seeing in our hospitals, most patients don't show up to the hospital specifically for withdrawal, right? They show up for life-limiting, life-threatening conditions like the ones you're seeing on the screen. And so when you start to do this work, it's not inviting patients who you weren't seeing before. These are patients who are already coming to your hospital, right? These are patients we're already seeing in our institutions. And hospitalization is a recovery opportunity. It's a reachable moment. So, up to 30% of patients self-discharge as a result of, not having not having treatment, not having their withdrawals appropriately addressed, fear of being mistreated by the staff, having opioid cravings. And we know that when we start buprenorphine, as an example, 72% of patients make it to an outpatient appointment after discharge, an addiction-related appointment, compared to only 12% of patients when we sort of just give them a resource sheet and say, here are the clinics, go forth and conquer, good luck to you. That doesn't work. What works is starting medication, providing counseling, have a peer recovery specialist. That's what works. We know, again, readmissions really, really high for this patient population. Even when we adjust for all these things on your screen, 1.7 times more likely to be readmitted, right? And yet there's so little that we do for patients across the hospitals in our country. 6,000 hospitals, by the way, in the United States, and by our very sort of doing the networking and the advocacy work that we do, I would estimate less than 10% have any sort of substance use related services. Mind you, when we start buprenorphine, when buprenorphine is part of the regimen, we reduce readmissions by 53%. There is nothing else that we do in the hospital that I'm aware of that reduces readmission by 53%. All right, I'm going to just skip ahead here because I know I'm running short on time and I want to take some questions here. So what did we do? We have a 200-bed academic hospital. We don't have addiction medicine services. And so what did we do? We empowered our existing team. The picture you're seeing on your screen are all folks who already work in the hospital. We didn't have a cost center. We didn't get a grant. We didn't, pay an FTE. These were all people who already worked for the hospital system who said, enough's enough. We need to do something different. And what you're seeing on the screen are physicians, our residents, our pharmacists. We have palliative care, internal medicine, psychiatry, social work. Chaplaincy got involved. So this is a team of volunteers who said enough's enough. We're going to do something a little bit different, and it's been successful. So this is our team. It's called the B team or the buprenorphine team. I'm not going to go into all of this detail right now in the interest of time, but essentially it's a volunteer group that has worked really hard to shift the standard of care, to make sure that we understand how buprenorphine works. By the way, very straightforward, very easy, very safe. We share that information with the entire institution, and then we help teach, right? The whole see one, do one, teach one of academic medicine is how we approach things at our institution. So we taught everybody about buprenorphine. We taught everybody about harm reduction. We walked them through their sort of first handful that they did on their own, and then we empower them to kind of go forth and conquer. And that's how we've been able to connect over 100 patients with outpatient care. So doing this work has allowed us to appreciate that we've been able to reduce stigma through education, through appropriate messaging, through facilitating really important conversations, and potentially most important of all is role modeling. When we started our program, I'm going to go back here for just a hot second. When we started our program, it was 3 people. It was myself, Blair Walker, who's our chief of consult liaison psychiatry, and Nick Christian, who's an internal medicine resident. That was the whole team. And you can see the team has grown, and this is only the folks who did sort of the teaching. The actual number of people who feel comfortable approaching patients with opioid use disorder now, dozens and dozens, and it's growing every day. It's because we role modeled evidence-based effective care. And at the end of the day, the bottom line is at our institution, we now know, and we preach as often as we can, that hospitals are critical access points, and that addressing OUD is now our standard of care. If you're admitted for medical consequences of opioid use disorder or intravenous drug use, we will address those, just like we always have. And in addition, we will also address opioid use disorder treatment as well. Okay, so as I wrap up here, what can you do today, right? I've given you kind of all this information. What can you operationalize and contribute today leaving this talk? So one is use person-first language. Use appropriate language. This is from the American Society of Addiction Medicine. On the left side of your screen are all the terms that you should stay away from. Don't use them. Don't write them. Don't speak them. Just completely delete them from your mind, right? The terms on the right, those are the terms that we want to use and the terms that we want to use in our documentation. There are many different forms of this. If you Google patient first or person first language substance use, you'll get all sorts of resources around this. Very, very, very important. I would encourage you to really think about structural barriers, right? Think about policies that are in place in your institution, in your city, in your state, in your, at the federal level, and how you as an individual or your institution can really start to influence some of those policies, right? Starting or stopping medications for opioid use disorder during hospitalization is an example. Formulary restrictions are examples. Improving care coordination at discharge is an example. And then the X waiver, again, more on that another time. It does seem like the X waiver is finally coming to a slow end. And then the other thing I'll add here, and I won't share the whole story in the interest of time here, but so much of what we hear in our administrative meetings, when we're working with trainees, when we're talking with family and friends, so much of the narrative that's out there in the ether, whether it's healthcare related or not, is negative. Yet there are positive stories, right? I can share dozens and dozens and dozens of positive interactions, positive stories of recovery that people with substance use have shared with me and that I have seen myself in the hospital. Those are the stories that we need to share. And so the picture on your screen was drawn by hand from the very first patient that we ever started buprenorphine for on in the hospital. And the story, which is about 20 minutes long, I'm not going to share it now, but we use the story oftentimes to get buy-in from our stakeholders. And essentially, all of the things you're seeing in his drawing represent his many years of substance use. It represents so much of the chaos that was in his life, so many of the unknowns that were in his life. But as he would describe it, the light in the top left corner, the sun, the light coming through sort of this dark, chaotic picture that is his life of addiction, was being hospitalized at our institution. That was the bright moment after over 2 decades of substance use, was being admitted to our hospital for 6 weeks for endocarditis, being surrounded by a supportive team, being started on an evidence-based medication, being linked with a clinic at discharge that could continue his care. that was one of the most meaningful moments in his entire life, right? And so we share the story every opportunity that we share this drawing, and it's a huge part of how we've built success at our institution. And now we actually have a large grant from the state of Texas to bring this model to other hospitals in Texas. So no longer will I be able to say we're the only hospital in the state of Texas doing this. And I'm very excited for that. We developed online modules around stigma. This was a grant through the Association of American Medical Colleges. It's about an hour or so to go through it. It is completely free of charge. You can incorporate it into any of your organizational plans around stigma reduction. It has videos of people with lived experience, interactive activities, and for physicians, social workers, nurses, and pharmacists, it includes free continuing education Category 1 credit. So check it out. It is free to use. It's free to promote. Please use it widely. Nothing would make us happier. I think you'll find it extremely useful, and it is not death by PowerPoint. It's a very interactive program. And then finally, I do want to just plug Shatterproof. Shatterproof and Dell Medical School have a partnership to help address stigma in the healthcare setting. There's lots of really great work that we're doing together and great work that's on the horizon. So if you're not familiar with Shatterproof, they're one of the largest nonprofits in the country, or the largest nonprofit that focuses specifically on SUD stigma. So if you're not familiar with them, please do check out their website. And that's the show. That's the lecture. This is my contact information. I do want to say, and I mean this so much, get a paper and pen out because I don't see the chat box. This is my cell number. I give this at the end of every talk, 201-390-9245. That's my New Jersey pride there, so I never change my number. So it's 201-390-9245. Please call anytime, anything that I or my colleagues can do to help you or your institutions. You can email, you can tweet. But thank you so much for having me today, and I hope we can stay connected. And if I have time, I think I have time for just a couple questions here.
You do. Thanks, Dr. Botner. Maybe just one or two. So I'm actually going to, for folks on the line, I'm going to prioritize, just in case we can't get to all of them, a couple that are less of the general type and a little bit more specific around some of the follow-up on what you did. One of them was about when you were building or sort of onboarding the project you talked about, what types of patient feedback did you get? I think you talked about that story after this question came in, but I think maybe some more color around the types of patient feedback that you got when you were building that would be helpful for some of our folks here.
Yeah, absolutely. It's a great question. The feedback that we have gotten has been just universally positive, and it's important to also emphasize that what we offer patients most of all is a safe space. And so, early on I've been doing this for 4 years now, so I'm still learning a lot. And early on, we were reading about buprenorphine, we were reading about the evidence, and we were reading about some other hospitals that have done this, outside of Texas. And so my space was, we're just going to start every patient on buprenorphine, and that's it. I mean, it was never actually intended to be this big program that it is now. And what we learned was very quickly is that that's not the answer, right? The answer is to provide a safe space for patients during hospitalization. Some of those patients, many of those patients will be interested in pharmacotherapy, whether it's buprenorphine or methadone, or if you're fortunate enough to have extended release naltrexone in your formulary, that many patients will be interested in that, but not all. And so taking more of a harm reductionist viewpoint on how we do this in hospitals is the right way. And that's what patients were responding to. They weren't necessarily responding to being started on buprenorphine during hospitalization, although the ones that were started were very appreciative, and we've had really good clinical success. And as I mentioned earlier, this isn't meant to be a clinical lecture, so I can talk to you about that separately. Clinically, it's been really, really successful. But what we hear more from patients is not about whether or not they started on medication, it's that they are in an environment where they feel like they can be themselves, where they can talk about their history of drug use, where they don't have to sort of hide things about their medical history that may actually oftentimes impact their medical plan. And so it's been really, really successful, but it's a good question, because we have to be very holistic in how we approach these things, and we have to be, probably more than anything else, willing to learn. There's so much that we have learned, and I'm more than happy to share with any of you who are interested But there's a lot to learn, especially if you haven't done this work before. And patients really appreciate when you show a genuine interest. Most of what I've learned in the last 4 years has been me saying to patients, I wasn't trained in this. I don't have all the answers, but I want you to help me explore this so that I can provide you with the best care. Most of our patients have never been spoken to that way by a health provider. So it's very empowering.
That's actually really interesting. It's not exactly what another question about sort of, what language can I use if I see stigma happening, in terms of intervening or how might I, have these conversations. That's actually gets a little bit at both in terms of really sort of, almost a scripted answer, but, genuine. That's very helpful. That little tag at the end sort of helps us answer one other question. I'm going to try, we have 3 minutes, but I'm trying to squeeze one more in. How do you measure success? Are there some quick, short, surveys or public domain things that you could, share with people, and then they go through stigma training and you see if they've had an impact or experience related measures? What kinds of measures do you recommend for folks venturing into this to try to measure success?
Yeah, it's a great question. To your point, probably more complicated than the 2 minutes we have left, but it's actually one of the main areas of partnership that we have with Shadow Group is to really come up with a metric that's easily trackable, specific around stigma. We don't really have that right now, and so in the absence, we look at sort of a clinical outcome. So how successful have we been on STAR buprenorphine? How successful have we been in patients transitioning to an outpatient clinic? What do our readmissions look like? So just to give, we have a paper coming out in a few weeks in the Journal of Hospital Medicine, but just to give you a quick overview, about 60% of patients continue outpatient addiction treatment, and that's within our safety net population. So, along any of our chronic disease diagnoses, 60% follow-up is considered pretty good. And then we have many of our patients who 6 months out are still engaged. We have a peer recovery program now as well, so that even if patients aren't started on pharmacotherapy, they still get ongoing sort of harm reduction care. And so we've seen the benefits of that in terms of, one, attitude in the community about our specific institution that we see, again, more anecdotally, but I can talk another time about how we measure that. It's more subjective, but we have good subjective ways to do it. And then also around, naloxone distribution and how many patients pick up naloxone at our outpatient pharmacy. So it's been a big community lift to try and track some of these more clinical measures. Our hope with the proof work is to come up with a way where we can be more specific around stigma, and that has to do with surveying clinicians about attitude and knowledge. But again, that doesn't get to the heart of the question, which is how do you get that feedback from patients? So that we're very interested in that and are going to continue to work on that.
Yeah, easier said than done, I think sometimes. Well, I am out of time. I'd like to squeeze in a couple of more questions. I think, folks, if you have them, Dr. Botner's graciously shared his contact information, and we can certainly reach out to get some additional answers to those questions. I really want to thank you. One of the comments that we got in the chat was that this talk has actually given someone hope. Sort of the unapologetic, frank nature in which you're addressing this, I think is refreshing and needed in this space. So we really appreciate you coming forward and sharing this.